Okay, so today we are going to discuss Mantoux syndrome. Before this, we have done Man1 syndrome. Mantoux syndrome is also called Siebel syndrome. Okay, and Man1 syndrome is also called Werner syndrome. Female with thyroid nodule, elevated calcitonin levels. So there is thyroid nodule plus elevated calcitonin levels. Calcitonin is a marker, tumor marker for medullary thyroid carcinoma. Okay, so before jumping into the details, let's have one slide before going into any detail. This is the best thing to study before starting Men 1 or Men 2 stations. So they will ask you a question like, oh, this is also a question included, that what are the types of Men syndrome and oncogene mutation and mode of inheritance. So we will cover up all these things. So the other question will be really easy for you. So men type 1, men type 2a, men type 1, men type 2. Then type 2 is also divided into type 2a and type 2b. Okay, so what's the genetic mutation in type 1 is menin gene on chromosome 11. Type 2a and type 2b, this is due to rat oncogene on chromosome 10. This is on chromosome 11. Okay, both of these syndromes, or you can say three of them, all of them are inherited by autosomal dominant manner. 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 So this is autosomal dominant. Okay, now we study the details. So what are the components of men type 1? So in men type 1 we have the parathyroid identifies a parathyroid adenoma. Okay, so parathyroid adenoma or hyperplasia, pituitary 70%, prolactinoma. Okay, so pituitary can be any tumor, pituitary adenoma, but prolactinoma is the most common. Prolactinoma is the most common. It can be ACTH adenoma, growth hormone secreting adenoma. And the third one is pancreas, 50%. Islet cell tumors, Zollinger-Ellison tumor, but the most common is this Zollinger-Ellison syndrome, cystrinoma. Also adrenal adenoma and thyroid adenoma, but they are very rare, very rare. Okay, most common presentation is hypercalcemia. Most common presentation is hypercalcemia. Since this is not MCQ exam, so but for MCQ's exam this is really important, this thing. The most common presentation of men type 1 is hypercalcemia. Okay, so men type 2, in men type 2 we have hyperparathyroidism, usually hyperplasia, pheochromocytoma and medullary thyroid carcinoma. This is the triad here. Men 2b is same like this. Men 2b will also have this hyperparathyroidism, pheochromocytoma, but medullary thyroid carcinoma. But in addition to morphonoid habitus means that the patient will be long and like Morphan syndrome, morphonoid habitus, and mucosal neuromas, mucosal neuromas. So, and some people say that like men 2b are like hyperparathyroidism, medullary thyroid carcinoma, and mucosal neuromas. They exclude this pheochromocytoma. Pheochromocytoma is more related to men 2a syndrome. Men 2a syndrome. So, having said that, we have studied this. Okay, we have studied this. So, we will go further. Now it will be easy for you. Okay, so we studied the scenario that female with thyroid nodule. So this is most probably this is medullary thyroid carcinoma because calcitonin is elevated. Calcitonin is elevated, and calcitonin is secreted by. Okay, so Thyroid has two types of cells: follicular cells. These are the follicular cells, and along with this we have parafollicular cells, also called the C cells. These secretes calcitonin. So this is actually the tumor of C cells. So thyroid nodule with elevated calcitonin is medullary thyroid carcinoma. So single best test to diagnose FNAC, you have to take FNAC. This is a thyroid algorithm. Pathology report: FNAC showed malignant cell features, amyloid deposits, immunohistochemistry stain positive with calcitonin, stain negative for thyroxine. What is the type of cancer? So medullary thyroid carcinoma. Listen, for other thyroid carcinomas like papillary thyroid carcinoma, follicular carcinoma, we have thyroglobulin as marker. But for medullary thyroid carcinoma, we have calcitonin. Why? Why this medullary thyroid carcinoma? Because it has amyloid deposits plus calcitonin positive on IHC. Okay, on IHC. So cell source: parafollicular cells or C cells. Why? What is IHC in simple words? It is a method of localizing specific antigen on tissue or cells based on antigen-antibody reaction. So how it works? The antibodies are usually linked to an enzyme or fluorescent dye. When the antibodies bind to the antigen in the tissue sample, the enzyme or dye is activated, and the antigen then can be seen under microscope. So what is the type of antibody antigen reaction in IHC immunohistochemistry? It is complement fixation, which is type 3. So what happens? Let's suppose this is a cell, a tumor cell. This is nucleus. There are antigens or like markers on the cell. So we have in IHC contain markers which connects with these, and these are linked to enzymes. These are linked to enzyme or fluorescent dye. So they connect with it. So this can then be seen under microscope. They are then activated. Okay. So clean up. So what happens that and this is the complement fixation. This is a type 3 allergic reaction basically. So we have another pathology report showing size, number of positive lymph nodes 2 to 6. Do TNM staging. So TNM staging for this is I think for thyroid carcinoma. So TNM staging is under 45, above 45, under 45, above 45. So I think this is for medullary thyroid carcinoma. Yes. So any T, any N, M naught. This will be 1. Any T, any N, but M1. Then it's stage 2. Okay. For OR45, T1, N naught, M naught. This is 1. T2, N naught, M naught, or T3, N naught, M naught. So this will be stage 2. What is stage 3? Stage 3 is T4, N naught, M naught, or any T, N1, and M naught. Still it's M naught. In stage 4, this is for stage 3. In stage 4, it will be any T, any N1, M1. So primary cannot be assessed. So it is TX. It is TX, cannot be assessed. Okay. No evidence of primary, limited to thyroid 1 centimeter or less. So it's T1. Greater than 1 centimeter but less than 4 centimeter, it's T2. Greater than 4 centimeter, it's T3. And T4 is extended BN capsule, any size. No regional lymph nodes is N naught. No metastasis, it's M naught. N1 is regional lymph nodes metastasis, and metastasis present, this is M1 then. So this is like this. If the patient develop hypertension, what do you think she might have? She will have pheochromocytoma. It's a feature of pheochromocytoma. This and it also comes in the triad. What are the other adrenal gland swellings? Other gland, so it can be infection, abscess, cyst, hemorrhage, hematoma, amyloidosis, and TB. Okay, and it can be benign, functioning or non-functioning adrenocortical adenoma or incidentaloma, congenital adrenal hyperplasia, ganglioneuroma, malignant, neuroblastoma, lymphangioma, adrenocortical carcinoma, and metastasis. METS. Okay, so how can you diagnose pheochromocytoma? So for pheochromocytoma, we will for pheochromocytoma we have plasma markers, urine markers, and imaging. Plasma markers: free metanephrine, catecholamines, catecholamine stimulation test. In urine, we have fractional metanephrine, total metanephrine, okay, and catecholamines and VMA, vinyl mandelic acid, which is commonly used. Vinyl mandelic acid in urine. And imaging: ultrasound, CT scan, MRI, MIBG scintigraphy, PET CT. MIBG scintigraphy is most commonly used for extra-adrenal or which cannot be located. Extra-adrenal or cannot be located, so we use MIBG, meta-iodobenzyl guanidine, MIBG scan. If the condition was familial, what other condition do you suspect? Parathyroid hyperplasia. So we have already in the scenario diagnosed medullary thyroid carcinoma. Hypertension है तो pheochromocytoma, and if it's familial condition with middle, so it will have parathyroid hyperplasia as well, because this is the triad. This is triad: parathyroid hyperplasia, pheochromocytoma, and medullary thyroid carcinoma. Type of Menn syndrome, oncogenic mutation, mode of inheritance. So we have already studied these. Okay, so what is the role of TENS in pheochromocytoma? So pheochromocytoma, 10% will be extra-adrenal, 90% will be intra-adrenal, 10% sporadic adrenal pheochromocytoma are bilateral, 10% are bilateral, 10% are sporadic, not in familial as we discussed earlier. We discussed the familial case like men, but this will not be familial. 10% sporadic, 10% bilateral, 10% extra-adrenal, and 10% adrenal pheochromocytoma are biologically malignant, 10% malignant, 10% extra-adrenal, 10% malignant, 10% sporadic, 10% bilateral, okay, 10% associated with hypertension, HTN, and 10% in childhood, children, and 10% familial, 10% familial. Okay, treatment of medullary thyroid cancer. I will do full examination, full investigation, and radiology. So I will also involve MDT and go for thyroidectomy with neck node dissection if positive lymph nodes. If positive lymph nodes, I will go for neck dissection. What are the type of neck dissection? Radical, this is old surgery. Modified radical, selective. What do we spare in modified radical? Internal jugular vein, sternocleidomastoid, cranial nerve 11, accessory cranial nerve. And in radical, we also cut these as well, these wider structures. So this is such a radical surgery, such a radical operation. Importance of immunohistochemistry. Immunohistochemistry gives you tissue diagnosis, cytology, as well as tissue receptors. What? Let me clear it. I'm going to write something very important for you. It gives you receptor evaluation, because receptor evaluation is very important. We know this in BRIST CA. Receptor evaluation, quantification, and types. So this is all about Mantoux syndrome.